Missing maps. The goal is to create digital maps of remote, somewhat forgotten places where vulnerable populations live. And why do we do it? We do it because, unfortunately, many areas around the world are strict by crises, by conflict, outbreaks, the disease outbreaks, disaster, earthquakes. And when we can map these areas, on one hand, it gives up-to-date data to humanitarian organizations to do better decision-making, but it can also give more power to those communities affected because this data is an OpenStreetMap, which is free and accessible to anyone. So they can also use this data when they're doing, for example, community projects or when they're doing participatory decision-making. These are some of the examples how we use the map data. I've already mentioned a few. So for example, for diseases, we used it for vaccination for measles, spalničky, or in case of Ebola outbreaks in the Democratic Republic of Congo and Sierra Leone, and also cholera epidemic. And another one that's important to mention is the logistics, because we could not have all our operations running without logistics, and to get enough medications there for the target populations, it's very good to have a precise idea of how many people live and where exactly they are spread. And here we can see who is behind missing maps. Hi, Edgar. Hi, Ashkan. Please come to the front. It'll be better for you when you're mapping, and you will be able to see better. Hi, welcome. Please take a seat and get comfortable. All right, so what unites these organizations that we have here, whose logos you can now see, is that they are the founders of Missing Maps, that we came together with the British Red Cross and the American Red Cross and the humanitarian OpenStreetMap team to start an initiative like Missing Maps, to map collaboratively with thousands of volunteers around the world. And thanks to that, we are here today, 7 years later. And now I would like to give you a short introduction of the highlights from the 50 years old history of Médecins Sans Frontières. At this spot, I would like to send some good vibes to Silva Horáková, who is our general director. You can see her on the picture, and who unfortunately fell sick with a cold and is losing her voice. So I'll go through the slides in her stead. But she says hi to all of you, and is very happy as well that you can support the organization. Those who come regularly to the Mapathons, you have met her. She also comes to the Mapathon. And she would have very much liked to share this moment with you. But here I'll try to take you through it. Often people say that a picture is worth 1,000 words. So let's start with a picture of our foundation. What you can see here is a picture from signing the MSF Charter. Anyone knows from which year this? Yes. 1971. Oh, right. I didn't realize it's on the picture. Of course. Well, right? So it came about in a way that in the year 1960, the French TV started showing for the first time pictures from conflicts around the world. And when young doctors saw these bloody images, literally children dying because of hunger, they wanted to do something with it. And so they went for a mission with an organization called International Committee of the Red Cross, or shortly ICRC, in Czech, Mezinárodní výbor Červeného kříže. And some of them were very young. For example, Bernard Kouchner did not even finish his thesis when he went, when the French Red Cross asked for volunteers to join these missions because they needed more doctors. They realized that in these places, they really needed to help those who were malnourished or who even had injuries from the conflict. And so he went to Biafra, which is a province in southeastern Nigeria. It's basically a breakout province where they declared independence from the rest of Nigeria. and it was surrounded by the Nigerian army, and people were dying of famine. And when these doctors saw it, they thought, well, the doctors need to go where the patients are, and we need an organization that can independently and neutrally give this sort of medical aid. And 2 years later, this was in 68, right? So 2 or 3 years later, 2 journalists from this medical review published an appeal to start a group of doctors who will do exactly this thing. And so these doctors, originally from the International Committee of Red Cross, they jumped on the occasion. And also when they were there in Biafra, they felt, but this cannot go unnoticed. The world needs to know that these people are dying of hunger here. We need to do something, right? And so this is how one of the key principles of MSF work was born, and that's the testimony, or in French, témoignage. That's also about seeing what is happening, where the people are in need, and why the help. Still in apolitical fashion, as much as possible. The idea is not to point fingers. Those are guilty, those are surrounding the others, and they let them die of hunger. No, it's really more to bring it to the world's attention to then be able to provide this humanitarian medical aid. And we fast forward now 50 years, and this is what we are now. Yeah, it's like a spider web. Can you see Czech Republic there somewhere? Yeah, so we're here. Does it work at 5 points? No, I guess. Basically, MSF, it has an associative structure. So we're a bunch of associations, operational centers, 5 operational centers that you can see here. And we belong under Geneva. And thus we are attached to Switzerland. So that's a bit of a look on our structure, but I won't go more in detail into it. But the idea is that it's not strictly hierarchical organization with one headquarters in, let's say, New York, and then offices in a bunch of countries that need to do what New York says. Almost everything is done by discussion, and we reflect a lot on what we do and why we do it and what we can do better next time. And as I've mentioned, we have projects in many countries. Last year, it was in more than 90 countries. And you can see that due to COVID, even Czech Republic is there, even France, Portugal, Belgium, Italy, because we run projects usually to help people who don't have much access to healthcare, or where the healthcare system was not able really to provide a kind of protection and support. So for example, here it was in the centers for seniors, and in Slovakia there was a similar project also in some Roma settlements. And here a few highlights from the history. So today we are 63,000 staff. 90% of our staff is from the countries where we work, so they're residents. The top picture is from Indonesia. The second one is a flying MSF tuberculosis surgery team in Yerevan in Armenia. The third one is after the Ecuador earthquake, the MSF response teams. The fourth one is MSF Zimbabwe team. The fifth one is in Niger, MSF answer to the cholera epidemic. That's why they have those protective suits. And then the sixth one is the MSF Czech team. That's a goodbye for our former director, Pavel. And there are even more because I wasn't on that picture. I joined just a bit later. Now, here you can see some medical highlights. What I wanted to mention is that we gave 9.9 outpatient consultations. So we have, more than 10 million patients, and also the surgeries number is in thousands. And it's often in places where people cannot go and see a surgeon in the regular healthcare. What you can see on this picture is in India from the World Patient Safety Day on the left side. Next to it, it's a center in Pakistan for cutaneous leishmaniasis. And the third one is from Iraq. It's a child being treated at a pediatric clinic. And then this one is from a conflict in the Central African Republic, an influx of wounded patients in Bangui. Some of the milestones. Oh, okay. These are just some of the historical moments that formed our identity. So I guess all of you have heard about the Rwanda genocide in '94. And that's when we realized that doctors can't stop genocide. There were discussions between our different operational centers like Amsterdam and Geneva and Brussels. Should we stay or should we go? And in the end, some of our operational section projects actually decided to leave, and some stayed and then realized it was really dangerous. And some of them had to back up a few months later. So that's why I think the principle exists that medical and humanitarian organizations work only where they can be with the agreement of the government, because once you're unwanted there, then it becomes very dangerous to those who provide the care. And the security of our staff is one of the first things that we have at heart so that we can continue to provide that care. Another important milestone is providing affordable medications for all those who need them. That's why we have the Access campaign. So this was in '99 during the Nobel Peace Prize speech. And the slogan is basically, what we demand is change, not charity. It's change in terms of prices of medications, provide them for the price of generics and not, so that most of the money from the patents goes to the medical companies. And that's something that we've been trying to also communicate during COVID, that the vaccinations need to be made available to the developing countries, to the countries that are unstable and in conflict, so that they can also raise their protection, especially of the vulnerable people like seniors and those who are sick. And yeah, medicines should not be a luxury. Another interesting milestone is the tsunami in Southeast Asia. We started a big collection, a crisis fund, basically. And people had so much solidarity that in the end, from different offices, we actually collected more than we could spend for this context. And so eventually we stopped the crisis funds, and we then contacted our donors and asked them if we can use these funds also for other operations, not in an earmarked fashion. So that was really wonderful. These are some sanitation kits. What do you think is in such a kit for displaced people? Just speak up. Or you can write in a chat as well. So these were distributed in Indonesia. Meanwhile, you think I'll give you a few more details. To internally displaced people who were staying in Teluk Kampong, in Teluk village, in 2019 in January. So what could be in a hygiene kit? Well, there's the bucket, the plastic bucket, soap, toothpaste, toothbrush, but also a towel or a sanitary napkin or detergent. Some of these things are really regular, but people who are stricken by a natural disaster, they just cannot afford it, unfortunately. And then diseases spread when there isn't enough hygiene. And then I guess last to mention is the Ebola outbreak. This picture is from the DRC, and that picture is from sanitizing the protective equipment, from sanitizing before going to the patients. And here, this graphic basically it shows, meanwhile, the system is dissolving. The doctors are crying out for help. And then when these pictures came to the media, then really the help got mobilized. And thanks to tracing, we were also able to stop the spread of the disease more effectively. And for the tracing, we use maps. I think Audrey will speak about this a bit more. And there are many more MSF interventions. If, for example, you work at a school, or if you're interested, you can Google this. There was the occasion of 50 years. So thank you for listening to some of these highlights. And now, without further ado, I'd like to pass it over to Audrey, who is the Director of GIS Services at our GIS Center.